circulation and kidneys caused by elevated blood pressure. It is a marker of subclinical cardiovascular disease. So as you see, we start with left ventricle and go with carotid arteries. We can assess arterial function and go into microcirculation, like here. Some forms of hypertension mediated organ damage are reversible with antihypertensive treatment, especially in children when we start early treatment. However, long-lasting exposure to high blood pressure and associated immunometabolic abnormalities is especially important in case of primary hypertension. It may cause irreversible damage despite normotension. So remodeling already started. Both European Society of Hypertension guidelines, pediatric guidelines, and American Academy of Pediatrics guidelines mention how to assess hypertension-mediated organ damage. What is important? The most important marker is left ventricular hypertrophy. So the most important method to use is echocardiography. We will not discuss it today in details. However, there are other methods of assessment of target organ damage. As I mentioned, it is assessment of carotid media thickness and assessment of arterial stiffness by pulse velocity. It's not obligatory according to guidelines, but it is mentioned. It is optional if there is such a possibility. So, a reminder, we can assess morphology, left ventricular mass, this assessment of morphology, and we'll give an answer if there is left ventricular hypertrophy, what will suggest long-lasting hypertension, and intima media thickness, the same, morphological alteration in the structure of elastic arteries. And we have also methods to assess function. We can, of course, assess function of left ventricle, so it's function echocardiography, and assess function of arteries by assessment of pulse velocity and assessment of pulsive analysis. It is one of the methods used by us using modern equipment. Of course, we can also assess function of endothelium, measuring flow-mediated dilation. As I mentioned, I will focus on CIMT and pulse velocity and pulsive analysis. So, it is subclinical hypertensive arterial injury, according to the definition, it is the name, and it is a marker of hypertensive arteriopathy, and pulse rate velocity is a marker of arterial stiffening. However, using pulse rate analysis, we can assess also some central blood pressure, because in some cases there may be difference between peripheral blood pressure measured on the arm and central blood pressure measured in the aorta, and we have indirect, non-invasive method of assessment of central blood pressure. So, a few words about arteries. Few kinds of arteries, starting from the large, so now central arteries. They are elastic. There is very small amount of muscles. There is large content of elastin, and their primary role is to store energy during systole and to use this energy to sustain blood flow during diastole. Second, there are medium-sized arteries. They are muscular type arteries. For instance, superficial femoral artery, we can assess the media thickness in this artery. They are smaller, 5 to millimeters in diameter. They are rich in smooth muscle cells and collagen. They are poorer in elastin and they regulate blood flow via vasoactivity. And of course, small arteries and arterioles. Those arteries are assessed by OCT or OCT angiography by ophthalmologists. So, how to assess arterial structure? Inelastic arteries, the place where we assess arterial structures is carotid artery, and we assess intima media thickness. We can assess, of course, it also in aorta. It is quite difficult and not used clinically. Most often we assess intima media thickness in carotid artery. Sometimes in femoral arteries. It is important when we have a child with aortic coarctation. So due to the lower blood flow and lower pulsatile flow lower in the legs, we can expect that IMT in femoral arteries and especially in superficial femoral artery will be lower than expected. Arterial function. Okay, we can assess also arterial function while measuring carotid media thickness. When we will measure at the same time blood pressure, we can assess also local stiffness of carotid arteries. There are some formulas to assess it. And we did it in some studies, like in ESCAPE study, where we assessed the local stiffness of carotid arteries in children with chronic kidney disease. However, it's not done on a regular basis. More often, we assess arterial function by assessment of elastic properties of aorta and large arteries by analyzing pulse velocity. It is a scan how it looks when we measure carotid intima media thickness. It is diffuse thickening confutimia and media of arterial wall, so it will lead to an increase of intima media thickness. It's not arteriosclerosis, it is arteriopathy. What we measure on the common carotid artery is not the bulb is here. It's not arteriosclerosis, it is arteriosclerosis. And it is a difference between pediatric measurements and measurements in adults. I will explain it in a few words after that. So, what are differences between adults and children? In most children, we cannot assess bulb and internal carotid artery. Bulb and internal carotid artery are easy to assess after pubertal growth spurt. In younger children, it is quite difficult to assess bulb and internal carotid artery, places where atherosclerotic plaques develop. So it's a difference. When we measure intima media thickness in adults, we average results obtained by measurement of intima media thickness in common carotid artery, bulb, and internal carotid artery. So it is a marker of arteriosclerosis and arteriosclerosis together. In childhood, we measure common carotid artery on the far wall. So it is principle because we always should measure INT on the far wall of carotid artery. But it's very rare for atherosclerotic plaques to develop in this place. So we assess arteriosclerosis. So it is different. There are general principles how to assess intima media thickness. It is 1 centimeter below the bulb on the far wall. And we have referential values for children starting from the age of 6 years, not in younger children. We have referential values. They are easy to obtain from the website of hypertension, and one can calculate SDS values when we know values of LN and S. It is according to the special formula to calculate standard deviation scores for intima media thickness values. Of course, we can also use percentile charts. A few words about stiffness of large arteries. There are several different parameters that may be used to evaluate arterial stiffness in children. In general, they can be categorized into first elasticity parameters such as distensibility, Young's elastic modulus. They can be assessed by ultrasonography, and we can assess it during measurement of intima media thickness. And what is most important is most often used in clinic is assessment of pulse velocity and pulse analysis, and some other parameters which are derived from these measurements, like central blood pressure augmentation index. How to assess carotid femoral pulse velocity? Carotid femoral because we assess speed with which pulse wave goes to the arterial tree from a large artery from the aorta to the femoral artery, and we assess two pulse waves on the neck, on the carotid artery, common carotid artery, and on the femoral artery. There are different methods used to assess pulse velocity, different because there are different devices. One group of these methods are devices which use applanatory tonometry, and other devices use oscillometric method. What is the difference? Applanatory tonometry is user dependent because someone must stick the beam to the carotid artery and the other beam to the femoral artery. Oscillometric methods are user independent, so easier in clinical use. There is a need to calculate the distance which pulse wave goes from the heart to the femoral artery. And there are different formulas how to assess this difference. Most often used in pediatrics is this formula where we calculate distance from the cuff on the carotid artery to the suprasternal notch, from the suprasternal notch to the umbilicus or femoral artery, and then subtract this distance from this one. Another method used in adults, in general, one can say that it should be used in those who already attained their height, so in adolescents older than 16 years. It is simply calculation of the distance from carotid cuff to femoral cup multiplied by 0.8, and it is formula used in adults. The second important point is that, as I mentioned, there are different devices used to assess pulsar velocity. So if you will have any value obtained by measurement, you should refer it to referential value. And those referential values are different for different devices, are different for oscillometric devices, are different for applanatory tonometry. So it is important to know if such a method is validated. And we have such a table where the most often used devices are listed, and as you see, there is some information about validation in children. Some of tonometry devices are validated in children, but also oscillometric device, bicorder, is also validated in children. Most important, there are normative values for these devices, both for tonometric but also for bicorder, which is oscillometric and which we use in our clinical practice. I must mention about the other method of assessment of stiffness of aorta. It is cardiac magnetic resonance imaging. It is not used in clinic on the routine basis, it's obvious. However, it is used in some research studies, and as you see, one can assess different parts of the stiffness of different parts of aorta, because aorta is not a uniform structure. Aorta is formed by at least 3 different parts, and one can assess pathway velocity in different parts of aorta. It is only to mention because it's not used on the routine basis in the clinic. The question is if there are any data showing that there is association of carotid diameter thickness and pulsar velocity with cardiovascular risk in children. Yes, we have a lot of data. We have a lot of data showing that CIMT is a good marker of arterial hypertension-induced organ damage, that the higher IMT in adolescence, the greater cardiovascular risk in young adulthood, and the same is pulsar velocity. And there are some groups of patients with chronic disease like CKD, like hypertension, which show, or diabetes, which show that there is significant association with increased carotid diameter thickness or faster carotid femoral pulsar velocity and increased cardiovascular risk in adulthood. So only to show you some results of some studies showing association between cardiovascular risk and intima-media thickness and pulsar velocity. But how it is in hypertensive children. Here are the data from the study from our group where we analyzed touched organ damage in children from normal tension to severe ambulatory hypertension. And as you see, there was linear increase in pulsar velocity from normal values to elevated values in those with severe ambulatory hypertension. What is important to note is when you will look into the values of pulsar velocity, you will see values like 6.1, 6.5, and we think that it is elevated because physiologically both carotid diameter thickness and pulsar velocity increase with age. So we must have referential values adjusted not only to sex but also to age. So 6.1 is normal value for 40 years old adult, but it's really elevated for adolescent. What is the difference between two markers? It is here you see the results of our meta-analysis prepared in hyperchild working group a few years ago, and we found that there are two different factors which cause arterial damage. First of all, intima media thickness is related not only to elevated blood pressure, but especially to all this metabolic soup where arterial death into children is pediatric with primary hypertension. On the contrary, pulse velocity is strictly related to actual blood pressure. So I mentioned about different methods, about oscillometry and ambulatory tonometry. A few words about oscillometric method. We need two cuffs above the common carotid artery and above femoral artery. We must know how to calculate pulse length. So it is most often used formula to calculate pulse length. And for adults or older adolescents, we can use European Society of Hypertension formula, simply measuring the distance from supersternal notch to femoral artery multiplied by 0.08. When assessing pulse velocity, we must measure at least 10 waves. It will be shown by Dr. Podylniak during the workshop. We have referential values assessed by recorder. It was assessed by records from Forcing Study Consortium a few years ago, and we have values which will help us with calculation of SDS values, but we have also another chart with values showing percentiles of the pulse velocity. From clinical point of view, it is most important to assess SDS values because we can compare values year by year. The other point I would like to mention is to look into assessment of arterial damage and assessment of CIMT and pulse velocity as a signs of biological aging. So the more stiff arteries, more thicker arterial wall, the older your arteries. And as you see such a comparison where we compared children from normal tension to severe hypertension, and we assessed CIMT and pulse velocity, there was increasing difference between vascular age, so values which were above the 90 or 95th percentile of referential values, and chronological age. So the faster pulse velocity adolescence or thicker intima media thickness, the older biological age. And how it looks when we compare such values when we do a meta-analysis. This meta-analysis shows that hypertensive adolescents at the age of 15-16 years, it is most common age of diagnosis of primary hypertension in pediatrics, have similar pulse velocity and carotid media thickness as normotensive adolescents or young adults already who are 4-6 years older. So it's our other view on assessment of arterial structure in children. A few words about pulse analysis. It is a part of assessment of arterial stiffness using bicorder. So a sensor detects pulse wave on the brachial artery, so not on carotid artery, but on brachial artery, right brachial artery, which is this pulse wave is subsequently analyzed by the software using special transfer function, which provides reconstruction of the shape of aortic wave. At the same time, we measure blood pressure on the other arm. So we have two values, one value of central blood pressure and value from peripheral artery, from brachial artery. There are other parameters which can be assessed. They include cardiac output, total peripheral resistance, and cardiac index. And software also provides information on the wave's reflection contribution, like as mentioned, central systolic blood pressure, and especially central blood pressure, augmentation pressure, and augmentation index. So, concluding, we can assess arterial structure from the aorta to the microcirculation. We will not discuss this problem today. We can assess structural injury by calculation of continuity media thickness, and when we will know how what are the distances in the systole and diastole of carotid artery, we can calculate also known wall cross-sectional area, which is a sign of remodeling of carotid artery. And these values and this marker is associated with metabolic abnormalities typical of metabolic syndrome. And we can also assess arterial stiffness of function of large arteries by assessment of femoral pulse velocity. So I think that we will still have some time to show how to assess pulse velocity, and I will ask